Good evening, everyone. Welcome to this webinar. My name is Averill Kelly. I am the Dean Emeritus of the College of Remote and Offshore Medicine, and I sit on the Faculty Advisory Board for the Faculty of Remote Rural Humanitarian Healthcare, which is running this performance tonight. And thank you for joining the Damage Control Procedures for Non-Surgeons in Prolonged Casualty Care. This evening's webinar forms part of our continuing series. This is the third series from our college that focuses on austere remote and humanitarian and conflict environments. So with me this evening are two doctors. One is Dr. John Quinn, who is an MD PhD. He has spent the last 25 years going to Ukraine and other austere environments. He's worked as an observer for OSCE and the UN. In Ukraine, he provides TCCC, prolonged field care, damage control resus, and damage control procedures training in collaboration with the college as well as other things. And he started off as a paramedic, which is one reason I've invited him on to this evening. He continues to conduct research in conflict and disaster medicine through the Prague Center of Global Health, and he's a member of our faculty at Quorum. Our second speaker is Dr. Tom Stevenson, who is also an MD PhD, who brings extensive experience in austere and pre-hospital medicine. He is a surgeon with the Royal Navy. His PhD thesis was on ballistic wounding, and he is also a faculty member of the College of Remote and Offshore Medicine. This is the third webinar in collaboration between our two colleges. These two colleges, the Quorum and Edinburgh, are two nonprofits that are trying to make a difference in austere medicine. So this evening, we will start with a presentation from Dr. John Quinn.
Thank you, Abrick. And I just want to do a shout out to the Royal College of Surgeons of Edinburgh. Thank you very much for this opportunity, this venue. Obviously, a thank you for the College of Remote and Offshore Medicine, as well as from the Disaster Health Institute, to which I'm kind of double hatting this evening and being able to represent both institutions and organizations to discuss with you and present some interesting findings over the last 12 to 18 months about damage control procedures for non-surgeons, really in that prolonged casualty care environment. So as we start all good things, we need to remind ourselves of the lethal diamond. I think it's very important to remind ourselves within the framework of trauma, why are we doing what we're doing, and that concept of the coagulopathy, the acidosis, the hypocalcemia, the hypothermia found within trauma and blood loss is something that we have to constantly come back to and remind ourselves, what are we doing? How are we doing it, and how is it going to affect or reverse this lethal diamond? So really, why damage control procedures? Well, Ukraine has really flipped the whole cart and the whole paradigm. The golden hour, the platinum minutes, the platinum 90 minutes, all these different paradigms are completely challenged, and they're in significantly challenged in these contested environments, which is Ukraine of large-scale combat operations, as well as within that hybrid domain. Medics are a target. We are all targets now. So being a target really affects our ability to do medical evacuation and really affects our ability to do the best that we can at the right place, at the right time, with the right patient and the right medical equipment. Delayed evacuation really requires a complete rethink of how we're going to do things. It's no longer, hey, I've got all this equipment, I have a lot of material and manpower, and I have a few patients. Now I have many patients. I have very limited manpower. I may have limited training, and I definitely have limited resources and equipment. And also, I think something really important for tonight, and I'd like to really put a stake in and a claim in here, the military and civilian interface for disaster preparedness. This is the same problem set that always has kind of been challenged and contested, and it should be. But really, for large-scale combat operations, especially right now taking place on the European continent, military problem sets and civilian problem sets are very, very similar. So we need to learn from one another. We have to prepare and train together. We also have to make sure that it's based in evidence and based in best practices. And of course, we need to have a governed bridge between damage control resuscitation and damage control surgery, and that's really where damage control procedures comes in. So just a little bit about organization and orientation of how this came to be, the concept of damage control procedures. The Disaster Health Institute is really the policy side, the research, the doctrine, the governance. Think of the ministries of health, ministries of defense, inside the Beltway, the Pentagon, former employees, etc., as well as people from the World Health Assembly and things like this. College of Remote and Offshore Medicine really are the people who jump out of helicopters, the doctors who run around and do really interesting things in the far forward space and do curriculum development, a lot of education, a lot of simulation, a whole lot of competency assessment. So you bring those two things together and you really can unpack, and this is what we've done for the last 12, almost 18 months now, is really unpack what do we need to do within the research, what does the evidence say? What do we have to do within doctrine, meaning how do we need to challenge that doctrine, or does it need to be challenged? And how do we need to devise the curriculum, which is what we're at right now, and then execute training and then have implementation and get feedback on how well it's working and what we need to change. So we've done elements of all of these, but really right now we're kind of sitting between curriculum and training because we're only doing limited damage control procedures concepts. Let's talk a little bit about definitions. I think it's very important. This is the academic side of me coming out. Damage control resuscitation is really clearly looking at how do we physiologically stabilize our casualty. And we know that we have to have blood, we have to have access to tranexamic acid, we have to consider calcium. There was a really good podcast recently by Dr. Andre Kapp, really focusing on calcium and where it's good, where it's bad, where we need to have that sweet spot, and also prevention of that lethal diamond. That is the whole process, the whole focus of damage control resuscitation. Give me access to blood and we can do damage control resuscitation. Then we have damage control surgery. That is great. Damage control surgery. We get surgeons. We have Dr. Tom on. He's going to talk a lot about really great surgical stuff. We need surgeons. We need access to surgeons. The only problem is medics are now targets. So it's very difficult to be able to get those surgeons exactly where we need them to be, as far forward as possible and as far forward, close to point of injury as possible. So we need that bridge. That bridge is the damage control procedures, right? And that squeezed in that middle, that blue box there. It's really protocolized. It is. There's no doubt about it. This is a protocolized approach to the procedures. It's time critical interventions. Really looking at non-qualified, non-surgeons that are qualified and trained under some governance structure, and to be able to provide very specific, targeted, executed interventions to be able to preserve life. And that's really what this whole evening is about. And I think it's going to be really interesting to unpack a lot of the details. This may look like a little bit of a busy slide. I just want you to focus on the gap. The gap is we've got stuff at Roll 1 and Roll 1 Plus. We know what to do. We've got a lot of people in the audience tonight, T-Tri-C gurus. They know exactly how to do the best of T-Tri-C. They can do it in really contested environments. They know how to do it when they don't have all the right equipment and they don't have all of the right cool stuff out of a great IFAC with all the fancy, shiny stuff. They can do all of that. And we've got folks that are excellent at surgical care, excellent at specialty surgical care, damage control surgery to the extreme. However, we do find ourselves in a gap, and that evacuation gap is really focused on that prolonged field care, the casualty care. That can be 1 day, that can be 3 days, and I've said it before, and it's really hard to believe, that can be 5 and 7 and 7+ days of time. So we think to ourselves, what are we going to do with that gap? Now, you may think, well, I come from a very large NATO army. I don't have to worry about that problem set. That may be the case, but it may also be the case that gap, that evacuation gap, that challenge, that problem set may come into our desks and our desktops and say, how are we going to account for this? What are we going to do to prepare for this potential evacuation gap? And this is where damage control procedures comes in. Really looking at that sensitive time sensitive things, really how are we going to enable evacuation, but also really reduce preventable morbidity and mortality with targeted interventions so that we can get that patient to definitive care, get that patient up the echelon of care to the next echelon of care through the continuum of care to the right place at the right time. So that's really the question. That's what damage control procedures is trying to do, is to address that gap. So what is it? Very simply, and this is, you can look at the tiers and people kind of freak out about lexicon and nomenclature, tier 1, tier 2, tier 3, tier 3+. We have different echelons where you find this. This is not a geographic execution. It's not. It is a training level. So these are different types of access to training, access to some form of competency. So if you take a look at the first one, and I will read out some of these, this is really our combat medic corpsman. This is our tactical combat casualty care. This is our basics. We have advanced airways, including a surgical airway, finger thoracostomy, tube thoracostomy, having access to blood and blood resuscitation with low titer whole blood, as well as other types of blood resuscitation, getting access to antibiotics, not just from the pill pack, but also IV antibiotics with good antibiogram data, tourniquet conversion, which sounds very simple, and downgrading and replacement, but it can be very challenging to train this, especially for people that may not have access to a whole lot of training in the past in the pre-hospital space. And then introduction to surgical equipment, different types of surgical tools and instruments and procedures, how to stay clean as you can be, forward analgesia, as well as sedation. So it's quite a big set. A lot of those things may look very familiar for a lot of you that are doing, T-Tri-C stuff and a whole lot of other pre-hospital stuff. And then if you go into that next phase and you say, well, what about that intermediate damage control procedures? This is peripheral and regional nerve blocks, external fixation of the lower limb, and I can go into more details, but the upper limb is very, very complex for external fixation, and there's quite a bit that you can do actually with basic splinting devices. Limited laparotomy. Limited laparotomy in trauma with packing. This is a considerable surgical intervention to do as well as not being surgically trained. So this is something we can go into a lot more detail, but this is opening up the abdomen, packing the abdomen, addressing visual bleeding, and then doing a damage closure. This is significant. This is a very big intervention. It's not something taken lightly. And then escherotomy. If you go into that next tier, that next phase, fasciotomy, decompressive trepanation, and burr holes for epidural hematomas with intracranial pressure considerations, which on one of our previous in this series, we were able to talk about how to do that and how to try to identify that with ultrasound, which is quite interesting, as well as the partial retrograde endovascular balloon occlusion of the aorta. This is partial REBOA. This is a big one. This is a buzzword for a lot of people. Some people love it. Some people hate it. Not a lot of people have done it. There's a lot of data that may be inconclusive. There's a lot of data that is actually quite helpful to understand where partial REBOA may fit in that pre-hospital paradigm, that pre-hospital space. We can unpack that with a lot of questions. I think there's really a cohort of patients that may really benefit from partial REBOA, and there's also a cohort of patients that may not. Field amputation of the upper and lower limb, that is tourniquet-based technique. And then really that tier 3 plus, which is some really, flat out sci-fi cool stuff. This is far forward, cutting edge, emerging platforms that are still under evaluation. However, they're being tested right now, and some of them being tested by NATO directly to include field hemofiltration, advanced neuroimaging, as well as advanced neuro monitoring techniques. So it's really interesting stuff that's tier 3 plus. Again, taking those advanced skills, advanced techniques, and pushing them down into the mid and low level provider. So some future direction, and then I'll hand over to my colleagues. We need to develop this internationally with accepted governance. We need to really expand research and outcome evaluation. And what that really means is we are still doing this in Ukraine. We've been doing this for some time, different tiers, different level of training on cadavers only, and really get some more feedback as well as some of the field experimentation as well as with patients, and get some of that feedback from our Ukrainian colleagues and other national colleagues on whether or not it's working and what they were able to do, and also some qualitative feedback. Also refining the curriculum and really finding within those tiers what is obtainable in a very short amount of time, and really getting a lot more of those lessons and observations from some of the publications that are coming out on damage control, resuscitation, and surgery. And again, the goal is to improve survivability, reduce preventable morbidity and mortality. I do want to have a comment about governance. The concept about damage control procedures is not to put these tools and concepts into the hands of mid and low level providers, send them out the door and say, go off and do these things. It has to be within the system. You cannot do some of these really intense surgical interventions without a system, without a process, without a plan of what is going to happen next. However, you will never get to that point if you do not have a lot of mid and low level providers with some semblance of training, not only for the basic stuff, which is very important. We will never get that advanced level of care until we have excellence in basic level care. However, we need to keep training and we need to keep challenging our mid and low level providers so that when we do have that system in place, we are designing that system on the fly mid flight. We have a system in place that we can actually plug those providers in and they can provide excellence. So I'm very much looking forward to discussion and questions. Thank you very much for your time, and I'm looking forward.
Thank you, Dr. Quinn. We do have a couple of really good questions on a Rebola and other things. We will discuss them. There's time for that after we hear from Dr. Tom Stevenson. Dr. Tom.
Thank you. Give me a moment while I just put my slides up. Great. So hopefully you can see that my bandwidth holds up. So yeah, I mean, thank you. Thank you. I just want to echo what John has said. Thank you very much to the Royal College of Surgeons of Edinburgh for the webinar, and of course to the College of Remote and Offshore Medicine, for whom I'm speaking alongside my expert colleagues today. I think following on from John, he's raised some fantastic points there. And if we move the slides forward, I think the sort of first opener that I would caveat from my own presentation is that I'm speaking with my colleagues from the college in my position as a senior lecturer, but my few views obviously are very much my own, and hopefully will stimulate some discussion, which I look forward to. So I think these are important issues that John has raised. I think people's perception of damage control and how that is practiced within the field setting it varies quite a lot across the globe. And I think hopefully when we get to discussion, we'll be able to take some questions and see what the sort of global thoughts from the audience are. Defining damage control procedure has already been very nicely done by John, but to reiterate, I think the tiered system is one that is a very helpful way to consider stratifying those different procedures. For example, tier one being some kind of access intraosseous or chest drain insertion, tube thoracostomy for my international colleagues, surgical cricothyroidotomy, and so on. Tier two then being something like limb debridement in the surgical setting with external fixation, and perhaps then tier three, something like craniotomy or burr holes. And it should be considered really what's the context of the clinical need. For example, is the setting that we're talking about in a war zone or conflict environment, or an austere environment that's obviously going to be under a very different, significantly different resource or skill constraint than the practice perhaps within a developed country hospital during peacetime, as an example. So in the case of an emergency where you've got a patient who's at risk of limb or possibly even life loss, medical practitioners, I think, often feel compelled to act to do something, where perhaps there might be a perception to suggest that having a go is better than letting a patient die without any intervention of any sort. So really, I think this represents a really challenging area of doctrine to try and determine what is the right thing to do. And I should be very clear that as a single individual, I can't give you all the answers to that, but rather just explore the topic for both interest and discussion. So who are non-surgical practitioners? Again, I think this has been considered nicely by John, but it does stand to reason that this essentially breaks down into anybody who is not a doctor, and I would say in particular, in this instance, not a surgeon. So this includes pre-hospital emergency care practitioners such as paramedics, military medical assistants or combat medical technicians, corpsmen, etc., specialist nursing staff, and also people like the surgical support practitioners and other healthcare providers or allied health professionals who've undergone some vocational training within their sphere. And I think it's important to consider whether or not these practitioners hold professional registration or answer to a regulating body from their home nation, with which we will come back to that a bit later. But the levels of training, I think, vary significantly worldwide, and qualifications that are recognized perhaps in one country may not be recognized in another. So the supervision and mentorship that those individuals may have similarly will vary a lot according to where they've come from, where their training was. And I think understanding a level of competence achieved by one individual can be really, really different to another if there has been a sort of non-standardized pathway that's been followed. And I think that is a challenge. The scope of practice, I think, encompasses what that practitioner would expect to do within their normal medical duties. So, as I said, different countries have different practices or different laws, at least, and guidance as to what constitutes a surgical procedure, similar to what we've just stratified. And also, I think it is common for the remote healthcare providers to deploy into the austere setting as part of a formal organization, such as with the military of their home nation, or with a non-governmental organization, such as something like the Red Cross or Médecins Sans Frontières, or similar to that. And I think that training pathways ideally should exist or do exist to allow certain procedures to be taught and undertaken whilst working within a defined scope of practice within that organization, but not necessarily independent from that organization. So you can kind of see there are quite a few nuances as to what constitutes a non-surgical practitioner, and you can start to see that the challenges that may be faced with that. So if we look at the existing literature, I think there's quite a lot of publications, to be honest, in journals from over the years, but I picked a couple out in preparation for the talk here, and I've come across in recent years. But this first one here is looking, as an example, at effective practice in emergency surgical procedures from nurse surgeons. So this is as an example, and this is nurse surgeons practicing in the United States of America, several countries within Africa, India, and others, and essentially demonstrated a series of procedures that were successfully undertaken, reported along with low complication rates. And by contrast, there's another paper here which focused more on aesthetic surgical procedures being delivered by practitioners using titles that cause some confusion amongst patients as to whether or not they are actually surgeons versus non-surgical practitioners. And actually, this paper then found that nearly 2/3 of practitioners presenting themselves as surgeons did not meet the criteria and regulatory guidance in the United Kingdom to call themselves surgeons, which is a pretty concerning statistic. And then the next publication I think is very much of value is, again, in the United Kingdom. After the 2024 revision of the Good Medical Practice document for GMC registered doctors, the Royal College of Surgeons of England set out the standards for surgeons practicing in the United Kingdom through the Good Surgical Practice document, which represents the core values, skills, and attitudes of the profession that all surgeons really should aspire to. And I would firmly commend a read. Finally, I think another important piece of literature to have a look at regarding one branch of non-surgical practitioners was the Leng Review, published in 2025, again in the United Kingdom. And that was published following a series of safety-related issues, amongst other things, regarding physician and anaesthetic associates, where the recommendations from the report essentially were as follows, which was to rebrand the role of physician to physician assistant, and I'll call them PAs just to stop my words tripping over, but PAs should be given an opportunity to undergo specialist training and development in context with formal accreditation to facilitate skills such as prescribing, ordering non-ionizing radiation investigations, and opportunities should be given to allow advanced level training with an appropriate salary banding to match this. The recommendations from the review also included that PAs should not see undifferentiated patients except within clearly defined national protocols, and newly qualified PAs should undertake a 2-year window within secondary healthcare prior to moving into any primary care environment, so out of hospital and into the community, and where the PA is employed, that a named doctor should take the role of line manager to that PA. The other sort of elements of the review included standardized measures, including national clothing, lanyards, badges, and staff information to distinguish the PAs from doctors, so that way the patients aren't under confusion essentially of who is providing their treatment at that moment. Standards of training and credentialing, again, listed as being provided by the relevant medical college via a permanent faculty that's been established to provide professional leadership. So essentially guiding the PA into developing into their future career role in a positive way. So I think, how do things work in the United Kingdom? Given that we have a lot of international audience here, it's probably worth going over this. Surgery on the whole in the United Kingdom is delivered by surgeons. So since 2008, there was a publication by Bentley and Church that detailed the need to move from a consultant-led service to a consultant-delivered service regarding UK medical practice. So the importance here lies in where a patient is not only knowing the name of their treating consultant, but also therefore knowing that consultant's practice, their credentials, their reputation, their experience, etc., rather than just being under the name of a consultant treated by a myriad of doctors of varying skill level and competence, of whom the patient may never then see again after a single treatment encounter. And the current practice in the UK is now a careful balance of consultant delivered service with appropriate supervised training for resident doctors to allow them to progress towards a career in surgery. And if I put that in context for you, an 18-year-old undergraduate starting at medical school, the quickest route in the UK to consultant surgeon would be 5 years at medical school, undergraduate level at a minimum, and often a lot of medical schools include an intercalating research year for a BSc, so up to 6 years there. 2 years of foundation training, 2 years of core surgical training, and then around 6 years on a specialty training program across the surgical subspecialties. And it's now relatively commonplace, particularly in trauma and orthopedics, to then undertake a fellowship of at least 1 year once that specialty training is complete, just prior to a consultant appointment. So this makes the quickest pathway to be about 16 years of training from day one of medical school through to day one of consultancy as a surgeon. And I mean, I can give you my own personal example. It's taken me 24 years to get from day one of medical school to reach consultancy for a whole host of wonderful life experience reasons with my career choices. But I can assure you that whilst I feel highly trained and I feel highly capable, it's definitely not an easy pathway to achieve. And my point, I suppose, is that, you know, despite all these years of training to become a consultant surgeon in the United Kingdom, we will have an expert level of practice within our respective fields as consultant surgeons, delivering remarkable clinical achievements, but none of us can provide a truly risk-free practice just due to the nature of the work that we do. If it was easy, anyone would do it, right? So the moment that delivery of that complex practice starts to be diluted with procedures that take years of experience and exposure to master being taught on a fast track to individuals, however well-intentioned, that don't necessarily have that same broader knowledge base and training years, then I think risk to the patient starts to increase. And this is no reflection on the character of those individuals who are seeking that additional training or that additional practice. I think the complexity of so many surgical procedures, even the inverted commas, more simple ones, should never really be underestimated. As often, I think many of these procedures are only ever really one small step or miscalculation away from causing harm to the patient or a poor outcome when those things go wrong. But I think, you know, I make it sound quite doom and gloom, but my words shouldn't be misconstrued to say that non-surgeons aren't capable of learning. On the contrary, I would say that many, many non-surgical practitioners are highly skilled, highly experienced clinicians that I have tremendous respect for, and at no point do I underestimate this. But my point really, I think, is to reiterate that surgery in the United Kingdom is something that requires a level of skill and knowledge that must be acquired, quite rightly, through a route that is approved by our regulating body, and in order to ensure that patients are kept safe as the first priority, and that we provide the expertise that really has become synonymous with a consultant delivered National Health Service healthcare provision. So if we think what defines a consultant surgeon in the United Kingdom, the Royal College of Surgeons of England listed a definition of the consultant surgeon in the United Kingdom, which is that of a registered medical practitioner that undergoes approved training and acquires appropriate experience to join the UK Specialist Register and is appointed by a recognised process. So the attributes for that individual should then that they should possess is then nicely summarised actually from another international document from both this document, but also from the Royal College of Physicians and Surgeons of Canada, using the Canada Medical Framework, which puts medical expert at the centre of the schematic you can see there, and then a series of attributes that come off there, of which I think the domains that you can see are all broad-based points that extrapolate to be of relevance to many of the clinical audience that will be here today. But you put that together to deliver the consultant as how many of us would expect that individual role to be. And I think it's certainly in the UK, it's a position of ultimate responsibility and is highly, highly challenging to achieve. So I think this leads us on to the discussion shortly. but essentially with how surgery is practiced and governed in this country, in the UK, I don't believe currently that this process should change, but that's not to say that it will never change. Currently, I don't support the idea of non-surgeons undertaking surgery, but particularly when considering the tiered structure. So operations like a laparotomy, limb debridement with external fixation, vascular bypass, amputation, even in damage control extremis, given the challenges and the complexity within which lies the pathway to training to become a surgeon. But I do think that there are certain invasive procedures. We've mentioned them earlier in the stratification, particularly in that roll wall environment. So access, interosseous access, tube thoracostomy, surgical cricothyroidotomy. There's definitely a place to facilitate a scope of practice amongst non-surgical practitioners that develop their skills and their ability for critical intervention on the basis that they have nominated and appropriate clinical supervision from a medical practitioner and have undertaken approved training and are accountable to either an appropriate regulating body or with a process of revalidation of the competencies on a defined regular basis. I mean, I'm open-minded as to what the future holds, but I think it is imperative to highlight that need, certainly currently, for both governance, accountability, and then overall patient safety when considering surgery on the critically injured. So I think that's I think opening up for questions and hopefully discussion points. And I look forward to then sharing across our faculty. There are certainly some references which can be recorded here for you to look up in your own time. But I'll hand back to the chair so that we can stimulate discussion.
Thank you, Dr. Quinn, Dr. Stevenson. Both had excellent presentations. Clearly a great deal to think about, and hope everyone appreciates this very difficult topic. And we can start with the questions. But we had 180 attendees who have shown up for this, and we have a whole queue of questions. And first on the list is from Nigel Rossiter. Sorry, Nigel, we've even had a chat. Sorry if I slaughtered your last name, but as a pillar in the community, his question was, Reboa should be probably put to bed. What's the discussion? John Quinn, I know your eye is twitching there a bit on this one. So let's talk about the elephant in the room. John, you'll start, and then Tom, you'll follow up.
Excellent. Thank you, Dr. Nigel, for the question and the frag out. I appreciate this. Full disclosure and bias. Last September, I received training, 2 days of training by the partial Reboa folks. So I received training and got to see how it worked, kind of got to ask a whole lot of questions, do this really cool clinical interaction. So I do have bias, obviously. I do understand that Reboa should likely be put to bed. However, partial Reboa, the catheter that actually has partial occlusion in zone 1, the data just has, I think it became FDA approved in October or something like this last year, so less than a year that it's had FDA approval. So the data really hasn't come to the fore. I do think there is a paper that will be published with less than 20 case studies from Ukraine for zone 1 with the partial occlusion, with the partial Reboa Pro catheter. And I'm curious. I mean, I'm completely open-minded. If it works, awesome. I'd like to know the cohort of patients that it will work with. And if it doesn't work, what are the cohort of patients that it doesn't work with? There's a lot of anecdotal evidence. I spoke to a lot of vascular surgeons and general surgeons that have used it in Ukraine. They've got mixed results. One had 2 saves, one had 2 losses. And there's obviously going to be a lot of publications that come with that. I don't know if anything in medicine should be put to bed. Obviously, leeches should have been put to bed in the 1960s and 70s. We're now seeing them come back. So I do think I'd like to have a bit of an open mind with the partial Reboa. I'd like the data to sort of tell the story. I know it's a very loaded phrase. There was this really huge study that took place on London HEMS with really damning, outcomes of it, which is great to read, and it's great to understand that. And I think I'd like to read the same paper with partial Reboa. That would be my take on it. But Dr. Tom may have additional concepts. But just to summarize and wrap, I do think data should tell our story for partial Reboa, and I do think understanding how it works as a mid and low level provider within the damage control procedures concept is important. I think being able to understand how to place it how to tell if it's in place, and how am I going to manage this patient? Am I going to remove this arterial line? Am I going to remove this catheter, or am I going to manage it and better understand how it works so that I don't see something that I have no idea how to do or how to manage? I would say I'd rather know how to manage it myself. But Dr. Tom, over to you.
Thanks, John. Yeah, I mean, it's a great question from Nigel. Um, I think so. I would caveat straight away that my practice as an orthopedic surgeon, in the different hats that I wear, Ribera is not within my deliverable skill set. Certainly not at the moment. And I have to say, despite the sort of early exciting literature from years back, I think the subsequent literature, certainly that I've read, for Ribera, is certainly not something that I would be advocating for. But partial Ribera, again, I think data is definitely a big thing that's required here. It's very hard to say never, never to anything in the medical world. Always and never. Two statements never used, he says, ironically, within the medical world. But I think currently, at this standpoint, I wouldn't be confident to say, oh, yes, no, this is something we must advocate for. I would want to sort of wait and see really what the medical jury throws out.
So to answer the question, it looks like there's a difference between Reboa and P-Reboa as we move forward.
Yeah.
Yeah, just to kind of talk about that in a little, just it's zone one, so you're going very, very high, and it's partial Reboa, which means the balloon can be complete occlusion, but you can also dial that down with two different versions. There's one which is a compass device, which you can dial down with numbers, being the pressure above the balloon and below the balloon, and one you can do digitally, if you have these big fancy pieces of equipment, and you can say, listen, I'm now fully have occluded the aorta versus I'm partially occluded, and then you can dial it all the way down. I am not a surgeon. I practice emergency medicine and pre-hospital medicine, but it'd be great to to get more feedback from the surgical side, from a vascular side, on the partial Reboa. But I just want to comment that evidence and data should really tell that story on whether or not it's good, bad, or indifferent, if it's equivocal. So I think data needs to drive our decision making on that. But the concept of putting it into the damage control procedures curriculum is so that if a mid and low level provider is all of a sudden landed a patient and they have partial Reboa in situ, they won't say, "What's that? How do I do it?" No, no, no. You need to understand how to assess it, how to see if it's secure, how to be able to understand, is it occluded? Is it partially occluded? Is it completely deflated? Do I need to do something with this? Is this causing the patient's deleterious effects or deterioration, or is it something that I can manage? I think that's the really important part, is getting that clinical ability to understand what you're doing and what's in front of you, and be able to try to manage it, as well as potentially place it. Obviously, if a surgeon is saying, yes, please place that, you need to be able to understand what it does, how it works, and be able to manage it and potentially place it. So I know that's just sort of from the procedural standpoint, a take home point on partial Reboa.
Tom, any rebuttal?
No, I mean, as I said, it's not something that's within my scope of practice. I think I'm very mindful that a lot of the cases, particularly, I think when you are a busy clinician, you may not have any kind of influence on what treatment has already been carried out when that patient reaches you. So it may be that you don't really get the choice of saying, oh, well, I don't think this patient should have this treatment. It's already happened, and now you have to deal with the consequence of that. Now, I'm not getting cynical as I get older, but I do find as a surgeon that you're partway along a chain, further up that chain or further along that chain, I should say, where other interventions have already been carried out, and the either the type of intervention or the quality of intervention, the situation within which that intervention took place, has a massive influence on the subsequent decision making that we have to make, sometimes at quite short notice. And I think things like Ribera in the pre-hospital space open a lot of doors to a lot of questions. And as John said, I think awaiting further data for something like partial Ribera and the variables within which the device brings, or the devices, is something to keep an eye on. But yeah, I mean, I will wait until there is more data.
I'll use a quote from Dr. Sean Keenan, who said, "There's more published articles on pre-hospital Reboa than has ever been placed a pre-hospital Reboa." So moving
True
on to the
words.
next question.
True word by the professor of pre-hospital military medicine. Yes.
What are the legal consequences of a laparotomy outside the OR?
Excellent question. And I want to jump in. Sorry if I'm jumping over. I think the governance piece is huge. The governance piece needs to be addressed on the limited laparotomy. Yes, right now, if any of you, after watching this webinar, run out and say, I know how to do a limited laparotomy, yes, you will definitely have significant clinical consequences. If you do a course in damage control procedures, that shows you how to do a limited laparotomy on one single or two cadavers. That is a completely inadequate amount of time. However, you now have exposure to a limited laparotomy. Now, whether or not you plug into your surgical system and do and support a surgeon doing limited laparotomies in the damage control space, and are observed to do that, and a surgeon feels comfortable with you supporting with a limited laparotomy, that is an entirely different question. But the concept about having a mid and low level provider do a limited laparotomy or support with a limited laparotomy is really where the damage control procedures process is. Being able to understand surgical procedure, being able to provide support and understand exactly what's taking place and where the bleeding may be and how to identify it, how to actually pack and do four quadrant packing and liver packing inside of an abdomen, understanding what you're doing, mechanically understanding, and from a protocol standpoint, be able to walk through what needs to be done. This is really what damage control procedures is being able to understand exactly what's taking place and be able to mechanically carry out that process. Now, whether or not that plugs into a huge system or not, this is the outstanding question that remains of how that plugs into that trauma system. And this is something that I think Ukraine has, in some instances, it has overcome this challenge, and it is able to supply a certain amount of training for mid and low level providers to be able to plug into a system. And in some instances, it may fall short. But I mean, that's basically the concept. So yes, it is absolutely illegal to do an equivalent laparotomy if you are not a surgeon in normal peacetime at a NATO or a European nation. However, when you're pushing far forward and inside Ukraine and inside large-scale combat operations with different types of clinical governance and crisis standards, that may be questioned, that may be challenged, that may be something that actually gets updated or changed. But Tom, over to you.
Yeah, I mean, again, I speak as a UK practicing surgeon, so the comment in the question was, is it legal to do it? I think, and I think it depend a lot on the country you're in, the laws within which you're practicing towards. I think my standpoint remains the same. I personally don't think that non-surgeons should be doing surgery, but I think John raises a valid point. I think if you've got a surgeon who is practicing in an environment at, say, a consultant or equivalent level to consultant delivered service, they may well have not necessarily a non-surgeon, but perhaps not another consultant. So they may have a surgical practitioner, such as a resident doctor or someone like that. There may be some scope for one or two cases that are going on with a supervising consultant stood there. But again, I think that's only an extremist. And, it's easy for me to sit here and make comments from, a chair in a room compared to being in the current challenges of overwhelming casualties in a war zone. I think that is, again, a caveat to all of this talk, actually. But yeah, I mean, I don't stray outside of the boundaries of UK law for my practice. And I certainly wouldn't advocate for somebody who's seen a YouTube video to then go and practice something, however well-intentioned. I think the complexities should not be underestimated. As someone who's taken 24 years to train to become a consultant, I think that the room for error grows wide when there is no depth of experience, and that is so it should never dissuade people from going to learn, to train, to learn new things and so on, or within that correct environment. But I don't think it's something that one just jumps into without appropriate sort of backup and training.
The follow-on question on that from Abdul is a good one. Medical legal protection. So what is protecting non-surgeons? Let's escalate that. Non-doctors to do these surgical procedures. John, let's talk about the CMC on the front lines in Ukraine. What legal protection? First, what are they allowed to do? And second, how are they protected legally as a CMC with 63 hours of training?
Yeah, excellent questions. So go back a little bit, take a look at the map behind me. The line is 1,600 to 2,300 kilometers, depending on how you calculate, and the day. 2,000 plus kilometers of line. There are warfighters from security services, the armed forces of Ukraine, the Ministry of Interior, the Ministry of Health, and other stand-up battalions. So there is no homogeneous clinical governance across that line inside Ukraine. It is a very challenged environment for clinical governance. There are very difficult laws that have been passed and are not adhered to just to be able to do blood transfusion in the far forward space over the past 5 years, arguably T-Tri-C over the past 12 plus years. So significantly challenged in the governance space. There are people that have gotten in significant trouble for doing relatively minor CMC level skills, such as needle decompression, intraosseous, which Dr. Tom was talking about as well. People have gotten in trouble for that. Say you're not trained, you're not licensed, you're not certified, you can't do this. One main elephant in the room is really the martial law. It's martial law. However, that has not been challenged, and no one really knows how martial law applies to clinical governance. I think a lot of people think that if a NATO Article 5 scenario were to be triggered and pulled, that all of a sudden there would be this blanket clinical governance for NATO and NATO armies, potentially NATO partners. That has not been challenged before. There's relative clinical governance work that has taken place in Afghanistan with the Article 5 scenario that took place. However, that was on expeditionary forces. That was not on NATO soil. That was not on a NATO country state. So these are really big questions, and the answers are right now very simple to just default to saying, listen, if you don't have certification, if you don't have state or national licensure to do it, it is 100% illegal. In Ukraine, they're facing the brunt of it. So they're doing CMC, combat medic corpsman training, and some of them are really just receiving the training. They have no certification. They may not be a nurse. They may not be an EMT. They may not be a paramedic. They may not have any certification inside Ukraine, and they're doing some of these basic and some of these advanced level skills, some with excellent outcomes and some obviously with less than excellent outcomes. There's a lot of transfusion that's taking place, potentially with great outcomes and occasionally with poor outcomes, overtransfusion, wrong blood being used, etc. It'd be silly to think that this does not take place with mid and low level providers carrying out in absolute crisis and stress situations, that there wouldn't be some sort of potential bad outcome. So the answer is yes, there are significant issues with all of these things, and being able to address these and being able to provide this training, I think, is absolutely the square one. This is the start of how to unscrew this problem. And there's also another question that I think really touches upon this. I'll let Tom obviously speak about the basics of tourniquet conversion and replacement. Huge problems, massive issues with people not receiving the appropriate training for placing a tourniquet and then being able to assess it within a certain time frame, currently under 2 hours. You can have a debate and argument about that. There's a lot of papers and publications about timestamps. Having said that, that is a very relatively basic skill that may be considered an advanced skill if no one can do it. The biggest issue is if you want to train 350,000 plus people on how to do something that is maybe basic, maybe advanced, tourniquet replacement, tourniquet conversion, you really need to be able to do that training in more than 4 hours, and in some instances more than 2 hours, right? More than just a video. As Dr. Tom said, you can't just watch a video and saying, oh, this is tourniquet conversion. You have to be able to do the training. You have to be able to show some level of clinical confidence as well as competence to be able to do that. So these are all very important clinical governance issues. I think the biggest question for Ukrainians are saying, that's great. As Dr. Tom has pointed out, it's taken him 24 years to become a surgeon, and Ukraine is losing several tens of thousands, if not hundreds of thousands of people. So what is their answer? Their answer is to train as many people as possible to the highest level that is possible at the time, because they're literally fighting for the right to exist. So that's a very challenging environment to do clinical governance, as well as to be able to have the appropriate amount of time, which may be 24 years. It may take 24 years to do this properly. And they may have less than 24 days before they go to the line. So that's a challenging environment. And the damage control procedures concept is trying to address in an emergency, one potential answer to that challenging question. So I answered a lot. I spoke a lot. I apologize, Dr. Tom. Over to you.
Not at all. Not at all. I think there's important topics to discuss. It's a great question that I sort of come back a little bit to one of my earlier comments. The question was around medico-legal standpoint. I think it's easy for me to make an answer to that if the situation is in the United Kingdom, but I think if you're somewhere else within the international stage, the laws of the country you're in. You mentioned martial law, particularly in the Ukraine, but this talk is not isolated to the Ukraine. This is the idea is damage control procedures for non-surgeons in whatever austere environment. That could be anywhere globally. So sort of sensitivity to the local cultures, the local law, as well as then the law of the nation that you are from. So, as you mentioned, John, are you someone who is trained within a body that you're working for, such as an NGO or the military or whoever? And it may be that your medico-legal standpoint is based off the regulatory body that you answer to as a professional. At the very least, that would be a start point to find information that is relevant to you as a practitioner. And similarly, if you belong to an organization that allows you to conduct a scope of practice, it may be that if you're working outside of that organization, you absolutely are not within a position where you can undertake the same scope of practice, despite experience. And that perhaps is the sort of the fail-safe, if you will, of top cover, for want of a better word, that individuals may have depending on who they've done the training with. But again, yeah, I think a difficult area. Again, easy for me to comment from a chair in a room versus in a situation of absolute desperation, I think, with numbers that are overwhelming. And as I said, I don't know what the future will hold with this. What happens if you lose your surgical capability and you only have individuals who have not got the same depth of experience or time or training or whatever? Do you say, oh, well, then we have to make sure that everybody is nothing, or that people try and do something? I think the moral component that comes with this, certainly as a surgeon, rule one from the oath is do no harm, right? So you have to be able to look at yourself in the mirror and know that whatever intervention that you have undertaken, effectively causing controlled harm to a patient, that have not brought harm or morbidity or mortality to them, because you've got to live with that if you've done that.
So a follow-on question. I'm a paramedic. We've been doing DCP for years, and then I'll bring up Tam White's comment about we used to do surgical cut downs on the the great vastus saphenous vein, and that was our IO. That's DCP. So should we be bringing that back if we are in a large-scale combat operations where IOs are gone?
So I think this comes back to John's sort of nice slide about the tiered system of what do you define as a surgical procedure. So I think Tam's absolutely right, and having seen him in action years gone by, the man he knows what he's talking about. And getting into access points and things like the pre-hospital space, if you can't stabilize and save your patient to move them back to the next echelon of care, then it's a moot point, right? So there are a defined scope of practice of skills that can be undertaken in the right setting with appropriate training, revalidation, accreditation appropriately. And a lot of organizations, either the military or NGOs, as we've described, will offer that training and then give that scope of practice with appropriate sort of oversight to those practitioners so that they can do these things. I mean, but there is the stratification is, what's the difference? There is a big difference between a venous cut down versus undertaking a vascular bypass, for example. And it's not to besmirch the comment at all. On the contrary, it's to highlight exactly that need for stratification. I think is really important. And these aren't decisions that are made by any one of us as individuals. This comes from consensus decision making from people, thankfully, high above my pay grade. But that's I think the open to discussion part that makes it of interest.
John, any comments on tier 1 level DCP? I think we might have frozen the doc.
Stunned him into silence. Force multiplication from damage control procedures that are undertaken is good. Sorry, John, we lost you.
Oh, I'm sorry. Apologies. Go ahead.
Say again.
I apologize for you getting lost there. My VPN just disconnected. So I went to my EMT school in the 1990s. And a lot of the old guys were the paramedic instructors were telling me about multiple different types of interventions that were really remnants of the are you still there?
Yeah.
Oh, sorry. Remnants of the Vietnam War for pre-hospital medicine. So I do think there are places, there are aspects that we should be able to harness and be able to take to the fore, but also remembering that we have had a history of taking pre-hospital providers and doing pretty advanced stuff. There was also a comment in there about, doing RSIs and some other really advanced stuff, not only in HEMS, but also in other pre-hospital areas around the world. It's not entirely an altogether new, but it is entirely altogether new problem set with large scale combat operations not seen for over 70 plus years. And really, weapons of war to include drones and fiber optic drones targeting medics. So that problem set is new. That's a new problem set. I would argue that that's a new problem set, and that it will require us to get new skills as far forward as possible and say, how do we get to point of injury? How do we get as far forward to point of injury as possible? Because we can't just sit and wait in a beautiful, nice, air-conditioned roll one or roll two. We need to be at point of injury or as close to point of injury as possible. And I think the Ukrainian experience, and I agree, this is not just about Ukrainian experience. However, right now there's some great information and data coming out of Ukraine for pre-hospital medicine, and what they're doing is they're giving mid and low level providers skills to be able to be at point of injury or be very close to point of injury to hopefully reduce preventable morbidity and mortality. And they're very successful in many respects, and of course there's also there's some challenges in other respects. But that's my take on the pre-hospital medicine. I think paramedics definitely and EMTs definitely have the ability and the historical wherewithal to be able to address a lot of these with the appropriate training, as Dr. Thomas has commented.
I'll follow that on with the CMC. I mean, that is the main medic on the front lines. So what tier do you suggest, what DCP skills do you suggest the combat medic corpsman, who on a good day will have an EMT and then follow it on with 9 days of CMC? What are we teaching them, or what would be allowed in Ukraine covered by MOI or MOH?
Yeah, I think that's a good question. So, it comes down to the distillation of who's willing to take on risk, right? So that isn't really something I can give a comment for to say which country is going to take on this risk to allow their providers to do the following practice. I mean, it's difficult. I think if you've got different people who have learned or trained in other countries, for example, to do surgical procedures in a different manner, then I can't comment for them. And as I said, I'm in a wonderful position where I can make a comment here, and it doesn't necessarily reflect world practice. All I've done is given an opinion that's essentially my own, from the practice of the UK, because that is the experience that I have. And then with the different guises of which I've practiced abroad have been under that banner essentially. And I think, yeah, if you've got a future move to then upskill people to provide or to develop a depth of experience that allows them to undertake whatever that practice is going to be under whatever supervision, then there probably is an area for development of that. It's just not something that I can predict of how that's going to go.
John, any comments on CMC tier levels for DCP?
We can get lost in abbreviations sometimes. There is a clear distinction between medical education and a medical practitioner, a medical operator, and a mid and low level provider. And sometimes that is a glass ceiling, sometimes that is an abbreviation or a certificate or a licensure. However, understanding the problem set and the challenge that not everyone can become a highly educated operator, highly educated medical practitioner, and understanding and identifying that in some instances, some of these advanced procedures and identifying through protocol, meaning it can definitely be messed up and it can definitely be misinterpreted, but through a protocol, some of these things can be actually trained and executed to good effect. But understanding that there is a distinction between the mechanical act of doing medical acts and the idea of saying, I understand what is happening and I have a good command of what is taking place academically and clinically. Those are two separate things. And at some point they join and people become a medical practitioner. And it is very challenging with a problem set to be able to say, well, we need a lot of both. We need a lot of both of these things, but we may not have them. So we have to figure out ways of how to produce the need and address the need really. And I think that's the biggest take home from that problem set. I'm not sure if that answers to your comments, but something that some feedback that comes to mind.
So one final question for the two gentlemen, and we've had quite a few questions on where and how, where to get this training. So as a critical care paramedic, there's DCP that you docs have already allowed me to have. So RSI, surgical airway, cut downs, which can't do that anymore, but I've been trained, chest drains, all these DCP skills, you have no problem with letting us have. So where where would somebody get some of the tier two, tier three DCP training?
Well, if you've got a spare 24 years, then at any point you'd be welcome to join in. But again, it comes down to that comment about, well, where are you in the world? I think different countries have different ways of practicing, and I don't think in any way that that should be underestimated. And I certainly don't. It's just not my experience. So I think if you have a country that has a practice that allows mentorship, guidance, development of practitioners who aren't surgeons to undertake whatever that procedure is going to be, then that stratification is born out of their own algorithm. It's not the same necessarily as what I understand or what John understands. So given the nature of the audience here, I think everyone will have their own knowledge of their own host country, of where they've come from, of how that training is then put into practice. So I can't give a single answer to that. I just know what the answer is for the UK. John?
Um, I would say there's a good comment here from Chelsea saying the David Knott Foundation. David Knott Foundation has an excellent course for humanitarian surgical interventions for surgeons and anesthesiologists. The Asset and the Asset Plus course. There's also an ATOM course. There's courses through the Mayo Clinic. There's courses through Cooper University in the United States. There's several pre-hospital surgical courses. However, you normally have to be a surgeon or a surgical resident or trainee in order to carry these out. The College of Remote and Offshore Medicine has already executed some tiers of this training in Ukraine, really for the past 3.5 years, elements of that. And there's also Rocky Mountain Aid Foundation, who do quite a bit of training in Ukraine, as well as the Disaster Health Institute, that collaboration between College of Remote and Offshore Medicine and Disaster Health Institute, and several other pre-hospital groupings. There was actually an Asset Plus course that just took place in Europe actually this month, and they did another iteration in early spring. So there's a lot of places to get this type of training, and I encourage all of you to reach out and get that type of surgical training as much as possible. The whether you are a surgeon or not a surgeon, being able to understand surgical interventions is very important. Especially in the pre-hospital space, if you're working in the pre-hospital space. What I will say is that this training is not a standalone. This cannot be all by itself training and then you walk away. This has to be a part of a system. You have to be able to plug into a system. So if you look at your systems level approaches within trauma and trauma systems, how are you going to be able to plug into that system and take that skill, if you do now have a new skill, a new surgical skill or peri-surgical skill, and how are you going to be able to plug into a system? It is a nonsense to go and deploy with all of these really hardcore stuff into a far forward environment, whether you're in Burma or Ukraine or elsewhere in the world, if you are not part of a system and you cannot plug into a system and have some semblance of a continuum of care. And if you identify that, hey, there's actually a continuum of care issue, address that continuum of care issue, and then be able to say, it's not only you that needs the training, it needs to be a large cohort of people that need training so that you can actually maintain and provide that continuum of care. I think that's something that I just don't want to overlook that and think that everyone needs to go out and do this for themselves. It has to really be a part of a system, and you have to be able to plug into that system. Those are the only comments I have.
I'm cognizant that we're 3 minutes past, but I would like to give both Doc John and Doc Tom an alibi if you guys have any further comments that you'd like to give.
Sure. I mean, just thank you very much for the opportunity, really. I mean, I suppose it's a challenging topic to discuss. That's why we have discussions, right? People have different opinions, and those are welcomed for discussion. I suppose my sort of final thoughts really is whatever it is you're going to do out in the world, so long as you can consider the following things, I think: governance, accountability, and then ultimately patient safety as the sort of forefront of practice, then good luck out there.
John?
Excellence in basic medical skills is the only way that we can provide excellence in advanced level skills. Damage control procedures is a brilliant resource. It's an excellent resource in the pre-hospital space. And as a lot of comments came through, we have to also make sure that before we do any advanced level skill, we have excellence in the basic life support. That's it.
On behalf of the faculty of the Remote Rural Humanitarian Healthcare and the College of Remote and Offshore Medicine, I'd like to thank everyone who joined us this evening, 180 people. And I'd like to thank the speakers, Dr. John Quinn and Dr. Tom Stevenson, who generously shared both of their expertise and experiences and willing to contribute to this webcast. But as medical professionals, we need to ask two questions. First, can we do something? That's the first question. That is never standalone. I implore you to follow that with the second, more important question, which is, should we? Make sure that you have both of those questions and the ethics to back that up. Thank you for participating and your great questions, 39 and counting. And we hope you found the session valuable. You can email me at aok@quorum.edu.mt if we didn't get to your questions. And thank you to the Royal College of Surgeons of Edinburgh for allowing us this platform. Have a good evening.